Okay, let's do another one. X-linked recessive. Here's a Punnett square. Okay, so the mother on the left-hand side there, um, XX going down. Okay, so she's a carrier. So the pink is signifying a carrier state, just in this example. Across the top, XY is the father, normal. He doesn't have anything. So the mother's a carrier of whatever disease we're talking about. It could be hemophilia, since that's X-linked recessive, or color blindness, since that's X-linked recessive. Either one of them. So the mother doesn't have the disease, but she's a carrier. The father doesn't have the disease, and of course, he's not a carrier, since he can't be. If he had it on his X chromosome, he'd have the disease. Okay, now just draw out the offspring, the 4 offspring, right? And whenever you're drawing out offspring, we always make it 2 males and 2 females because each one has a 50-50 chance of being born, male or female, okay? So in the top left square, XX, that's an unaffected girl, okay? Um, Top right, XY, completely unaffected boy. Bottom left is a carrier state girl, so she's a carrier for the disease, but she doesn't have it. And finally, XY at the bottom right, that's a boy that now has the disease, such as hemophilia. So what's the chance of passing on hemophilia? If your mother is a carrier and the father, of course, doesn't have the disease in this case, 1 in 4 chance. 25%. What's the chance of having a boy with hemophilia? 50% chance. Okay, because we've taken out the girls. We're asking what's the chance of having a boy with hemophilia? Okay. Okay, so let's go through a couple more relatively quickly. Because once you understand the concept of the Punnett square and what to put along the top, say the mother, and the father along the side, and then you can figure out the offspring. Okay, let's look at the left parents here. The father has an X-linked disease. Okay, let's call it hemophilia. Hemophilia is a recessive disease. You need both alleles to have the disease if you're a female. Well, because you only have one X chromosome, if you're a male, you just need one X chromosome to have the disease. Okay, the father has the disease. What's he going to pass to his sons? Only going to pass the Y chromosome. Neither of them have the disease. What does he pass to the daughters? He passes his X chromosomes to his daughters. They are carriers since they got a normal X chromosome from the mother. Nobody has the disease. Both daughters have the disease, and both daughters are carriers, and both sons aren't carriers, and they don't have the disease. Okay, let's look at the one on the right. The mother is the carrier for hemophilia, which again is an X-linked disease, just like on the left there, and it's recessive. So if you have 2 X chromosomes, you're going to need both of them to have the disease. Okay, let's look at the children. Okay, so the sons are going to get the X chromosome from the mother, because they only get the sons get a Y chromosome from the father. So they have a 1 in 2 chance of getting the abnormal X chromosome from the mother, since the mother has 2 X chromosomes. Look at the first son, normal. Okay, he got a normal Y chromosome and a normal X chromosome. It's normal. The daughter, so the second one, got the X chromosome from the dad, totally normal, and the affected X chromosome from the mother. She's a carrier. Look at the third child, a boy. Got a Y chromosome from the father, got the affected X chromosome from the mother. He has hemophilia. And finally, the last child, a daughter, both X chromosomes, one from the father, one from the mother, normal. Okay? So remember, when you're doing a Punnett square, we use 4 children as offspring because we just assume that 2 of them are going to be girls and 2 of them are going to be boys, since there's a 50-50 chance of having a boy or a girl. Okay? And then we just follow, is it a recessive gene or is it a dominant gene? Okay? Okay, going along here, I've mentioned Huntington's disease, so if you totally get it, then just skip this slide. So let's look at, say, on the left side, where there's a big H and a small h, say that's the father. And at the top, small h, that's the mother. Okay? And you have to have the big H to get it. Huntington's disease is autosomal dominant. Just need to get one abnormal allele, and it dominates the phenotype. You get the disease. Okay? So if you look at the Punnett square, if you've written it out, well, you can see right away how many offspring have the genotype for Huntington's. 50%. They have one capital H. So 50% of the offspring will get Huntington's. Does it matter if it's a girl or a boy? Absolutely not, because it's not linked to the sex chromosomes. So if you have 4 children and you have 2 girls and 2 boys, it might be the 2 boys, or it might be the 2 girls, or it could be 1 boy and 1 girl. Has nothing to do with the X chromosome. Okay? We're talking about an autosomal dominant disease here. Okay? Okay, so let's just look at a few symptoms and signs that occur in patients with Huntington's chorea. So this is a neurological condition. It's genetically inherited in an autosomal dominant way. And typically, patients don't begin having symptoms until around the age of 30, 40, or even 50. And once they're diagnosed, typically the lifespan is around 10 to 15 years. Okay? So there's motor changes. So they have difficulty controlling motor movements. And that's where the term chorea comes in. It's these uncontrollable movements of their arms and legs and their facial muscles. Dystonia means dystonic movements. The muscles are tight and stiff. Dysarthria means they have difficulty speaking. Dysphagia refers to the fact that they have difficulty swallowing. They have a poor posture, very uncoordinated now in terms of, say, holding a plate or grabbing a glass. Okay, impaired gait is another motor sign. They also have cognitive changes, right? So they're losing their cognitive abilities to perform normal tasks. They have difficulty concentrating. They have difficulty with impulse control, meaning their speech may suddenly be interrupted by shouting and screaming. They're disinhibited. And as well, now there's psychiatric symptoms. So depression, suicidal ideation. So all these are occurring because of the neurological changes that have occurred because of this autosomal dominant disease that's occurred. Okay, so I won't spend any more time. This is just to show you some changes that occur with Huntington's chorea. Okay, and this slide's just reminding you of autosomal and X-linked diseases. So as we just spoke about Huntington's, that's an autosomal dominant inheritance. meaning you just need one of the alleles to be defective from your mother or your father to have the disease. Okay? And for many years, for the first 25 or 30 years, you may not even know that you have the disease unless you go for genetic testing, because typically you know one of your parents has the disease. Okay? Marfan's, another autosomal dominant inheritance. Autosomal recessive conditions, cystic fibrosis, sickle cell disease, Tay-Sachs disease, and PKU, phenylketonuria. Cystic fibrosis is that condition where you have abnormal secretions in your lungs. You have thick, tenacious sputum. These patients often develop chronic bronchial changes, and they're very prone to pneumonia. They're also prone to other conditions because the thickened secretions are also occurring in the biliary system, such as in the pancreas, right? So they're not producing their normal digestive enzymes, and this results in malabsorption of food, right? So they can have issues with weight loss. They can have issues with digestion of proteins and fats and carbohydrates. So these patients often need to take pancreatic enzyme replacement in order to help absorption. Okay. Sickle cell disease, again, autosomal recessive. It's a condition of the red blood cells where the red blood cells don't always maintain their nice biconcave shape, and under stress, or if someone has some kind of other illness, the red blood cells can sickle. And when they sickle and turn into these very odd shapes, they can't go through all the small capillaries to different organs. And they get plugged up in these little capillaries. And that results in severe pain in these patients, because wherever the blood cells are now sickling and getting stuck in capillaries, those organs are going to have ischemia, or they're going to infarct and potentially die, the organs, that is. So sickle cell patients often have chronic pain. They can have chronic bone pain, for example, because the blood supply to the bones becomes blocked and ischemic, and they have severe bone pain. They can actually have blockages of the capillaries to their spleen, and they can have splenic infarcts because of the blocked blood supply. Okay, and this can happen all over their body. It can happen in their brain and result in strokes. It can happen in their heart and result in heart attacks. So all over the place, these cells, these red blood cells, are sickling. So typically in this disease, patients need a lot of opioid analgesics because they're in chronic pain. Okay? And how can we help reverse the sickling of the cells? Well, the cells usually sickle under some kind of hypoxic stress, meaning low oxygen in the blood. Okay? So providing them with oxygen by nasal prongs or by mask can help change the red blood cells from sickling cells back to normal shaped red blood cells. Okay, so it's often a combination of treating their acute illness, whether it's a pneumonia or any other illness, which will, if we treat the illness, it'll reverse the sickling, and also providing them with large amounts of opioids to treat their severe pain. Okay, so the next one is Tay-Sachs disease. Again, autosomal recessive. meaning you need both alleles from the parents to inherit this disease. And this disease is destruction of parts of the brain in the spinal cord. And it usually presents in infancy and typically results in death around the age of 4 or 5. And these patients develop difficulty with movements, they develop severe seizures, and there's no cure for Tay-Sachs disease right now, unfortunately. Okay. The last one, PKU, this one is screened at birth. Okay, so infants or newborns get 2 tests at birth. They get a TSH to check for any thyroid issue, because congenital hypothyroidism is relatively common and very correctable. And the other test they get in hospital is a PKU blood test to check for this inherited disease. Okay, so now PKU, what does it cause? Well, it's a deficiency of an enzyme that's responsible for metabolizing phenylalanine, which is just an amino acid. And it builds up in the bloodstream and it damages the brain. It leads to cognitive disabilities and seizures and multiple other mental disorders. Okay, so if this can be picked up at birth, then it's very treatable, because they can go onto a diet that's very low in phenylalanine. Okay, the excellent conditions I won't spend too much time on. The first one, hemophilia, is a X-linked condition, meaning if the mother has the trait, then who's going to get hemophilia? Well, it's going to be the sons, right? Because the mother gives the X chromosome to the sons, the father gives the Y chromosome. And this is a clotting disorder. It's an absence of certain clotting factors. So these patients typically bleed significantly. Okay? There are replacement clotting factors now that patients take to keep their clotting factors at a good level to prevent significant bleeding. Okay, so let's carry on to the next slide. Okay, so let's do this question together. Which statement is true about an individual who is a carrier for cystic fibrosis gene? Okay, so if they're a carrier, it means that they don't have the disease and only one of their alleles is defective. Okay, so the other allele is normal. Okay, so automatically they're heterozygous, right? They don't have identical alleles. So A is definitely out. B is definitely out. Okay, C, heterozygous and suffers from cystic fibrosis? Definitely not, because in order to suffer from cystic fibrosis, you need both alleles to be defective. It's an autosomal recessive disease. Okay, let's look at D. Heterozygous, yes, they're heterozygous because there's only one allele affected. Does not suffer from the disease, from cystic fibrosis. Yes, it's D, right? Okay, so remember, heterozygous just means that the alleles are different. Okay, so one's effective and one's defective and one's not. Homozygous means that the alleles are the same. Okay, so if you have 2 completely normal alleles, you're homozygous. If you have 2 completely defective alleles, you're homozygous. Okay, so if we were to think about an autosomal dominant disorder, you can never be a carrier, because as soon as you have one allele that's defective, well, you're going to have the disease. You won't be a carrier of the disease. Okay? So when we're talking about carrier state, we're talking about recessive conditions. Okay? So understand the term carrier or trait of an inherited disease, right? So if you are a carrier of a disease because one allele is effective in the setting of a recessive condition, you don't have the disease. And the same goes for trait. Okay, so those terms are interchangeable. Okay, you have the potential to pass on the defective allele, but you don't actually have the disease. Okay, so the next question here, if you have a mutation of one allele for a trait, do you display the trait? So if the trait is recessive, meaning you need two alleles, then no, you don't express the trait. It doesn't become your phenotype, right? You don't get the disease. If the trait is dominant, so autosomal dominant, for example, then yes, you'll express the disease. You will have the disease because it just took one allele to acquire the disease state. Okay. Okay, so we spoke about cystic fibrosis a bit already. So it's an autosomal recessive condition, and it causes a variety of symptoms and signs, right? So remember, you need both alleles to have this disorder. So it has an incidence, meaning out of every 3,000 births, one person will be born with cystic fibrosis. And you need both parents to be at least a carrier. Okay? So if both parents don't have the disease, then there's a 1 in 4 chance of the child having cystic fibrosis. Okay? And really what's happening is that there's an abnormal enzyme that's required for transportation of chloride ions. That's the underlying problem with cystic fibrosis. And because of this seemingly minor abnormal enzyme dysfunction, you get a host of different symptoms and signs. So in your respiratory symptoms, you get really abnormal production of thick mucus in your bronchial tubes. You end up with a chronic cough. You have recurrent pneumonias because your lungs are so affected. Sorry. In your gastrointestinal system, it can lead to pancreatic digestive enzyme deficiency, because all those ducts that are trying to secrete digestive enzymes out of the pancreas, they're all filled with mucus, and they're blocking all the secretion of the enzymes. Okay, so that results in really poor absorption of fat and fat-soluble vitamins. And what are the fat-soluble vitamins? A, D, E, and K. Okay, and the same thing occurs in your liver, where a lot of the ducts and the tubules are blocked with thick, sticky secretions, and you can get liver injury from cystic fibrosis. Okay, and the pancreas can be affected more than just its exocrine function, where it secretes enzymes for digestion. The pancreas is also responsible for producing insulin. So as the pancreas is more and more damaged and destroyed by cystic fibrosis, patients can develop diabetes. Okay? And there's also reproductive issues infertility, because all of those little ducts are also filled with thick, tenacious secretions, and that can result in lack of sperm in the semen. It can result in thick mucus in the fallopian tubes, so in all the reproductive tubes that are responsible for the ovum, the egg, to get to the uterus. Okay? Okay, so let's look at this slide and look at some features of cystic fibrosis. The common ones in particular. Okay? So let's start on the right where we see abnormal sweat secretions. Okay, so high chloride in the sweat. And actually, there's a test called a chloride sweat test that can determine if someone has cystic fibrosis. That was one way of determining the diagnosis because of the abnormal chloride levels. Okay, pancreatic insufficiency. So all those enzymes that can't get into the gastrointestinal tract to help digest, in particular, fats, and absorb the fats and the fat-soluble vitamins into the body. Okay, diabetes, because the pancreas is gradually being destroyed. Finger clubbing is where the ends of people's fingers they look swollen and they almost look like a small club. You should check a picture of finger clubbing. And this is very common in chronic respiratory or chronic cardiovascular conditions. So congenital cardiovascular conditions, where a child is born, say, with a hole in the heart, or something that they've had since infancy, or chronic respiratory conditions such as cystic fibrosis. Okay, you get clubbing at the end of your fingers. Osteoporosis is going to be from poor absorption of minerals such as calcium. That's going to lead to weakened bones. Male infertility because of all the mucus in the tubules. Arthritis, again, there's going to be poor mineralization of the bones because of a deficiency in absorption of calcium and also of vitamin D, right? Which is one of the fat-soluble vitamins. Steatorrhea just means oily stools, okay? So you're not absorbing the fat because your pancreas isn't functioning properly. So the fat is going to end up in the toilet and it's going to float on top. And we call that steatorrhea. Distal intestinal obstructions, purely because of all the thick mucus secretions in the intestine that can lead to a blockage of the tube. Okay. Liver disease, we spoke about because, again, of all the thick secretions in the liver tubules. Bronchiectasis is just a term for chronic destruction of the bronchial tubes with excessive mucus production and a chronic cough. Years ago, patients, and when we didn't have antibiotics, patients would have bronchiectasis and they'd basically have a little cup beside them that they would fill with phlegm and sputum all day long because they developed an infection in their lungs. It couldn't be treated. It permanently damaged their bronchial tubes, and it kind of festered and formed damage to the bronchial tubes, resulting in chronic mucus and phlegm and a chronic cough. That's bronchiectasis. Okay? Repeated lower respiratory tract infections in cystic fibrosis, that's purely because of the abnormal secretions in all the blocked bronchial tubes. And the same would go for the top one, chronic sinusitis. It's purely because the drainage from all these sinuses that actually want to drain, some of them actually drain into the nose, and the passages are blocked because of the thick secretions. So most of these symptoms and signs can be figured out just by what's happening, what's the underlying condition in cystic fibrosis. Okay, so let's do another question. And these questions start to be a bit fun if you understand, well, what's homozygous? What's heterozygous? What's dominant? What's recessive? And once you have a feeling for that, the questions are pretty straightforward to figure out, especially if you use a Punnett square. Okay? So if an unaffected mother carries one normal allele and one mutated allele on her X chromosomes, because females have two X chromosomes, what are the chances that she will transmit the defective gene to her sons? Okay, so when we do a Punnett square, there's always 4 offspring, right? So we calculate the percentage. Okay, so what are the chances she will transmit the defective gene to her sons? Well, so she has 2 X chromosomes, one of them's abnormal. So every time she has a child, she's going to give either a normal X chromosome or an abnormal X chromosome. And the father, in order to have a son, is going to give a Y chromosome. So there's a 50-50 chance she's going to give either the normal or the abnormal X chromosome, right? So it's 50%. Okay, we're getting there. Okay, Marfan syndrome. So Marfan is an autosomal dominant inherited. Okay, just need one abnormal allele from one of your parents. Okay, so typically you're going to know that one of your parents has Marfan syndrome, since it's expressed in an autosomal dominant fashion. Okay, and what happens in Marfan's syndrome is that the ligaments and connective tissue is very abnormal. Okay, so these patients grow to a very tall height. They typically have long digits. In actual fact, if they were to put their arms straight out, the length of their arms from one side to the other is actually taller than they are. Okay, so they have really long arms and long legs. Okay. Now, because of the abnormal connective tissue, well, this is going to affect many areas of the body. So they can have leaky cardiac valves because the tissue is really floppy. So the valves just don't close properly. So they're leaky. The tissue that's holding the lung against the inner chest wall can separate easily, resulting in a pneumothorax. Okay, so that's not uncommon in patients with Marfan syndrome. The ligaments that are holding the lens in the eye are loose, so the lens can actually dislocate out of its position and end up floating in the back of the eye. Okay, the aorta that comes off the heart, that's under a lot of force. It's constantly being exposed to high systolic blood pressure with the pumping of the heart. And the aorta can tear. Okay, so that's called aortic dissection. And that is one of the leading causes of death in Marfan syndrome, aortic dissection. Okay, they present with severe ripping chest pain and back pain. And what's happening is the aorta is tearing because of the abnormal tissue. Okay, so often these patients, if they develop that, they have already been told, you need to come right away if you get chest pain, because we have to rule out aortic dissection. Okay, and these patients often need cardiac surgery because of leaky valves. They may need eye surgery because their lens dislocated. Okay, so think about very loose, weak ligaments all over the body. Okay, a lot of these patients can actually bend their fingers all the way backwards because the ligaments are so lax. Okay, I won't spend too much time on PKU, autosomal recessive. What's happening? It's missing an enzyme that breaks down phenylalanine, okay, which is just an amino acid. So if you're missing the enzyme that breaks it down, phenylalanine is going to build to very high levels, okay? And as I mentioned before, that's why we do a phenylalanine test at birth. Okay, we do a PKU test at birth in all infants. Okay, because that elevated phenylalanine, if left unchecked, will lead to all of those symptoms on the right. Okay, all of these, for the most part, they're neurological symptoms. Okay. So I won't go over all of those symptoms. Take a look at them, but also understand autosomal recessive buildup of phenylalanine in the brain.